Thank you, Mr. Chairman. Professor Abridaki, many congratulations on your professorship. I'm very glad to see many familiar faces in the audience, specifically the guru, one of the gurus of Greek gynecological endocrinology, Kostas Samaras here. I'm going to present you a case, a clinical scenario that we see every day in our hospital, and I'm going to provide you with some essential information not only on hormonal management, but also on some clinical details of this person I'm going to present you right now. And this person is a 39-year-old nulliparous patient who complains of abdominal pain. She has a unilocular 4x4 centimeter cyst in her right ovary on ultrasound. The tumor markers are normal. And from her family history, the only important factor is that her mother's sister died age 45 of breast cancer. So her gynecologist goes ahead and he does a laparoscopic excision of this cyst. He ruptures the cyst during surgery at removal. And 2 weeks later, the histology shows a micropapillary serous borderline tumor. To remember, we have to pay tribute to Phanestil, because Phanestil is not only known for his Phanestil incision, but also because he was the first actually doctor who described very accurately borderline tumors, although it's been forgotten. And it's very essential reading this paper. And I would like just to give you very quickly a few things of essential knowledge for the borderline tumors. There are 3 characteristics. The first one, they are characterized by high cellular proliferation index. They are low-grade tumors, and there's no stromal invasion. That's how they are differentiated by invasive carcinoma. And they're very frequent neoplasms. We all of us have to know it. They constitute about 1/5 of the ovarian neoplasms. But contrary to invasive cancer, they are characterized by early presentation, so they mostly present as stage 1 at surgery, and they have excellent prognosis. So according to the latest theory of the guru of gynecological pathology, Kerman, you see that there may be the precursors of truly invasive low-grade ovarian carcinoma. So we have to take even this into consideration in our management. And as you see here, the age at presentation is much earlier than ovarian cancer, and mostly presented at stage 1, and they have excellent survival. Most of them, they are serous neoplasms. You see here on the right, a moderate atypia and no stromal invasion. But there is a certain entity we have also always to remember, the micropapillary pattern of the serous borderline tumors, which is characterized by a more aggressive, sometimes pathway in terms of prognosis and the possibility of having a different kind of clinical behavior. You see here foci of microinvasion in serous borderline tumors, and that's exactly what is more likely to happen when we have a certain pathology, this micropapillary pattern of tumors. What is important from the clinical point of view for our trainees, that I'm very glad to see most of them here today, is that we have to look for peritoneal implants, that they define somehow the behavior of the disease. And peritoneal tumors are a deposit of this kind of tumor. However, most of them are non-invasive as the borderline tumors in the ovary, but there may be invasive implants that we will find if we extensively surgically stage these patients. And that's exactly what we have to look for when we operate on these patients. We have to look for foci of aggressive patterns of behavior of these borderline tumors. So the first question for our trainees is whether the patient had the right operation or not. She had only a cystectomy and the cyst was ruptured at surgery. As I told you before, the prognosis of these tumors is excellent. However, if they are diagnosed in a more advanced stage, or if they exhibit features of like invasive implants, the prognosis is completely different. The standard management of the borderline tumors is a very thorough surgical staging, which means that this patient ideally should have a pelvic clearance, omentectomy, peritoneal biopsies, ideally a frozen section if it's available in your hospital, and thorough exploration of the abdominal cavity to look for implants which will define further the management of the patient. However, because this patient, as I told you, is an nulliparous patient, conservative management of borderline tumors is feasible in the majority of cases. However, we have to, of course, we preserve the uterus and the contralateral ovary, but we have to completely remove the adnexum on that side and to do the rest as we would do even if we didn't want to preserve her fertility. So, answering the first question, whether the patient had the right treatment, surgical treatment or not, the obvious answer is no. The patient should have had a completely thorough surgical staging, of course, with preservation of the uterus if this was to be proven feasible according to the histology, if we didn't have invasive implants or if we didn't have extensive high-stage disease. Another point is, of course, we can do a laparoscopic staging of these tumors. However, we have to know not to rupture, shouldn't rupture any cyst whatsoever, especially in this kind of tumors, because we know that there's a very high recurrence rate compared to not rupturing the cyst. And this is very well documented knowledge of the recurrence risk, which is 3-4-fold higher compared to non-rupturing the cyst. Now, this woman also will want, presumably, to get pregnant later because she's nulliparous and we preserved her other ovary and the uterus. And the other thing we should know is whether we remove the ovary, the whole ovary, or just the cyst, the fertility potential remains the same. It doesn't change whether we're going to remove the whole ovary or not.
That's debatable.
Okay, well.
It's very debatable.
Okay. Now, the question is, the second question I want to pose to you is that her mother's sister died at the age of 45. So we have only one second-degree relative who died of breast cancer. We don't have first-degree relative with any known hormone-dependent cancer. And what are her chances, you think, of her carrying a BRCA mutation, a genetic mutation? Let's look at this because it's quite important. First of all, is she a candidate for genetic testing? According to the latest guidelines, the Bethesda, the Amsterdam criteria, which have been updated by the Bethesda criteria, any woman, any young woman is a candidate for BRCA testing because her chances are much higher, are at least tenfold compared to the general population to carry a genetic mutation. We have to know that there is a 50% risk of recurrence with a dominant model, somatic model, but also we have to be specific when we take history to look for both men and women hormone-related cancer because both of them can be carriers. It's not only a woman in the family who can be a carrier of BRCA defective gene. We should know this. And basically, we are looking at 10% of all cancer cases that they may be genetically determined. We know where to look very easy now. We have many labs in Greece that they test for BRCA mutations. Greece has probably a slightly different profile to other BRCA patterns that they have been described, but there are minor differences, and we have very reliable labs on this even in Greece now. This is a typical pattern of BRCA that we don't inheritance that we don't see in our patients, because you see here generation after generation we have both ovarian and breast cancer. And if we suppose that this woman was a BRCA carrier, her chances of getting BRCA cancer lifelong risk is very high, as you know. Even with BRCA2, as Professor Vlachos said, maybe at a later stage, and is a slightly lower but very high risk compared to the general population, even of developing ovarian cancer. So, if you can get an algorithm to remember what are the chances of a person being a carrier of a BRCA test without doing the test. Her chances are very high if you have many cases, more than 50%, but they're about 10% to 15% if there's only one case. So in our history, in our case, I would say that her chances are about 10 to 15% because there's no first-degree relative with a documented hormone-dependent cancer. She doesn't have a high chance of being BRCA positive compared to the 50%, for example, but she does have solely on her own history and possibly related to her auntie's history, we have grounds even for this lady to do a BRCA testing according to the Bethesda criteria. And this, what I'm saying, has been recently reaffirmed by this state's data that basically if you have a person young person who presents with an ovarian cancer, she will have an at least tenfold chance of being a carrier compared to the general population. So suppose she's, yeah.
Okay, can I interrupt because I'm a little bit confused. If the chance was less than 10% if she has one relative.
It's about 10% if she.
Yeah, but she less than 40. But now her aunt was 45.
Yeah, but
so one relative 45.
Yeah, but
40.
she doesn't have any first-degree relatives with a documented.
So it should be less than 10%.
Yeah, but she suffered at a very young age of ovarian. Of an ovarian neoplasm. So solely,
is there
even
if you have borderline,
but even if
you have borderline, is there?
That's the only thing is the BRCA patients tend to be high-grade serous.
No, so it's not related to borderline.
Most of them they're high-grade patients, but we have. You find cases borderline tumors associated with breast cancer tumors in the same family. It's not, most of the cases will be, as you say, high-grade aggressive tumors, but you can get low-grade carcinomas with genetically inherited cancers that you see perhaps not exactly related to BRCA1 or 2, but you have to take it into consideration. You cannot avoid a possible relationship, which, in my opinion, should be about 10% in this case, considering her auntie's history, and also considering that perhaps we have missed another case in her family history.
But these are assumptions, though. I mean, the cases you have a woman with borderline tumor who has an aunt who had ovarian cancer, invasive ovarian cancer at the age of 45.
Yeah,
so
she died of breast cancer at the age of 45, yeah.
Breast cancer, 45.
Breast cancer, yeah.
So, if it was ovarian cancer, I would probably, but for breast cancer...
The majority of cases, as Professor Kicho says, are high-grade ovarian cancer, invasive ovarian cancers, but in the literature you see even borderline tumors appearing in the pedigree of patients with BRCA mutations.
They do?
Yeah.
They do.
There's
Evidence that
but most of them, they're exactly as you say. Most of them are high-grade tumors. Anyway, because the true case, this lady had a BRCA test and she proved BRCA positive.
But that's relevant. I mean,
Okay.
But my point is, because I think taking a woman with borderline tumor and says that you have 15% of developing invasive cancer, it's a big statement. I think, I don't know.
I think this is a very complex area. I think the pathways for borderline tumours are probably very, very different to high-grade serous. High-grade serous are probably fallopian tube carcinomas.
Yeah.
The genetic testing, I'm not aware of. I think if you test people, you will file BRCA positive. And remember, some of them will never develop ovary or breast cancer.
Yeah.
It's not a guarantee because you've got the mutation, you're going to get the cancer. So serendipitously, you can check somebody and just happen to be positive, even if they've got a borderline. What I wasn't aware of is that borderline tumours and their association with BRCA1 and 2. I always consider them in a separate issue. Now, if you have a case where you're getting borderline tumours with implants that have an invasive component, that's probably a different area, and I'm happy to sit back and say, I don't know, but I can see where that possibility exists.
Okay, okay, that's fine. So now this woman is BRCA positive and she needs to get pregnant. She had a fertility preserving surgery. She does have a uterus and other ovary. Now, what's the evidence regarding stimulating drugs, something which was asked before, and her risk of developing some other hormonal malignancy in the future? So far, and we have here the expert, from what I understand from the literature, there is an increased risk of developing borderline tumors, but not significantly increased risk of developing truly invasive ovarian cancer with stimulating drugs for IVF. This is well documented on both sides of the Atlantic, and this is data from France. These are where there's a risk of recurrence associated with IVF treatment. And there's another very big Dutch cohort which shows that there isn't much increased risk of ovarian cancer, but there's a 6-fold increase of borderline ovarian tumors associated with. So this does not preclude this person of having IVF in order to have a baby, but in the way I interpret the results, but this means that she should have a prophylactic surgery as soon as she completes her family. Do you agree with that?
I think, and then I think it's part of the consultation, present the data, and then the options that you may have is do stimulation, get the eggs, get the embryos, freeze them, remove the ovaries and the tubes anytime you want, and then transplant in the uterus. Then you can actually give her a little bit of a leeway to decide if she wants to have one baby now, one baby. Feeling.
I mean, it's all changed nowadays, but I think this is the best study. I know Kurt Berger, who did this, and they were really meticulous in getting the information. So
how do you advise your patients?
So the first thing, I mean, you're going to do IVF on her. Hopefully you've got a bit of normal ovary. You probably want some of that. And her risk of a borderline, well, she doesn't have a risk because she's already had it. So I would have thought what you're saying is get on, get your family complete, and then do a clearance. The reason we're doing that is because of ignorance at the moment, because we've always done it. I suspect there's many cases we're operating on, we don't need to do anything at all, but we just don't know, and the classic medical thing is, let's go for safety. So I think I'd go for family, get on with it.
So you agree with this statement, prophylactic salpingo-oophorectomy after completion of the family no later than the age of 40 to 45. Remember this person, when she presented, she was 38-year-old.
But if she has BRCA, then it should be earlier.
And exactly, that's the other point. The later you have the prophylactic oophorectomy, the protective effect on breast cancer. Now we have to know that the women who are BRCA positive and they undergo prophylactic oophorectomy, the ovarian cancer risk, of course, is reduced greatly by 96%, but also the breast cancer risk is reduced by 50%. This is a very well-known fact for at least 15 years now. I'm not going to enter the discussion about prophylactic mastectomy because it's a different issue here. Now, the main question for this seminar today is whether you would prescribe HRT in this case. And let's see some facts. First of all, I think the panel would agree that, as Professor Vlachos presented, I think, the same thing earlier, there's no evidence why we shouldn't give hormone replacement therapy in ovarian cancer patients.
First of all, it's borderline.
No.
Yeah.
Yeah.
This is the
No.
case is a
Yeah,
borderline.
yeah.
So there's no
Okay.
argument there,
Yeah.
right? Do you agree with that? Borderline, she takes hormone replacement therapy if she has definite treatment.
That's one thing.
So
Generally speaking, there's consensus, even with ovarian cancer, among the members of the panel that unless there are other contraindications or specific reasons other than the histological diagnosis, you would normally prescribe HRT on this patient. Regarding her BRCA status, would you agree that you would also prescribe HRT even if you knew that she were a BRCA carrier or not? From what we know, I think we can prescribe safely. We don't have randomized data, but we have long-term cohort data that we can prescribe HRT even with breast cancer with BRCA carriers. Let me just, but this patient had prophylactic surgery, and this may influence the way we think about HRT. If she's going to have prophylactic surgery, that could be much easier for us, because if she's going to have a hysterectomy at the time of the removal of her remaining ovary, then you would be happier to prescribe estrogen-only HRT. Would you agree, all of you? And this is the NICE Institute recommendation, not a direct recommendation, but NICE accepts somehow estrogen alone to prescribe in this sort of scenario. And basically, when we have a patient who is a high risk to develop a hormonal cancer and we are going to do a prophylactic surgery, we rather remove both uterus and the adnex at the same time, because that will also have an effect on how we are going to manipulate her hormones with HRT. In Greece, there is a shortage of estrogen, as far as I know, Professor Labrinoudakis. Is it true that it's hard to find estrogen now? But would you agree that this would be the best way to give her estrogen at the age of 45 or patches? So these are the limited data we have on BRCA carriers with HRT, that there's no increased risk. And we have to think also about estrogens and sexuality, because Professor Vlachos has gone into details on that earlier, but we have to remember that not only estrogens, but other potent drugs can be used for her sexual symptoms. An open question, I don't know what is happening in the UK, Professor Kicho may enlighten us, but we have Blissel in Greece. Do you have Blissel?
No. Israel.
Blissel is vaginal gel, which supposedly is not absorbed into the systemic circulation, and it does miracles. But we would be reluctant to prescribe it in a cancer patient. But well, it's supposed not to be absorbed through the systemic circulation.
But even if it is absorbed, what do you care?
I mean,
if we agree that she can
exactly,
take the parts as well.
I wouldn't have any doubts to prescribe Blissel for severe dyspareunia for this patient, but we should never forget, even the reps are outside here who support the seminar, this pH regulators and Replens is a very good drug as long as you use it properly. And I want to conclude by the statement of the American Endocrinology Society. They still very reluctant to prescribe HRT for cancer survivors, hormonal cancer survivors, but they reiterate the very good effect of systematic use of venlafaxine. We use it also in Greece very often. I have very good experience with Effexor. And we have to remember that there are studies which show that Effexor has equal effect against anorgasmia, pain and vaginal dryness. So if it's true, then why should we discuss about hormones? Thank you very much.